Hello, my name is Dr. Shway Malik. I'm the oral maxillofacial surgeon, and on behalf of the Maxillofacial Institute of Implantology, today we're going to talk about bone physiology and osseointegration. Both of these are extremely key point and fundamental for implantology and from the surgical point of view. A lot of people ask me about, why am I using this type of implant, or why are we, doing angle implant over here? Well, all of that is due to the fundamental understanding of bone physiology and osteointegration. Like I said, it is a dry topic, but once you get a keyhole of this subject, it'll really make surgical treatment planning of implantology a lot more easy to understand and a lot more predictable when you're actually doing the surgery. Okay, so let's start. We'll first talk about bone function. One of the key things that we probably don't talk about too much is bone is a reservoir for calcium. So, your hormones and your endocrine system help regulate the calcium from bone. So, for example, if your body needs more calcium, it takes calcium from your bone away, and vice versa. If there's too much excess, either it secretes through kidney or it kind of serves a purpose and reservoir in your bone. So it's a good reservoir for calcium um, in your body. The other obvious functions we know about is protection, it protects the brain, support for your muscular system, and to be able to provide support basically for the entire body. And for us, obviously, is supporting the structure of teeth. But just on the side note, when we talked about bisphosphonate related osteonecrosis, or patient that come with parathyroid hormone or postmenopausal, all those medically compromised patients, obviously we have a completely separate detailed chapter for it, but at least understanding how all of that does impact bone. And if anything that impacts bone obviously affects our treatment planning, our surgical protocol. So, three basic type of bone cells. You have your osteoblasts, which are basically originally the mesenchymal cells that are slowly turned into osteoblasts. And then these osteoblasts, their primary job is to lay down bone. And when they lay down bone, they get trapped inside of their own bone. And once they get trapped inside their own bone, they do become what we call osteocyte. So osteoblasts make bone. When they become trapped, they become osteocyte. And the osteoclasts are monocytes. They're multinucleated, and basically their job is to remove and bone resorption and clean it up. And like we talked about the parathyroid hormone, so this is where also when you're removing bone, you're also releasing calcium from the bone. And anybody who has issue with parathyroid hormone, then you will know their calcium would be affected. Just rough, just to show you these cells. So this is what the osteocyte would look like as this trap with a bone around it. You have your periosteum on the outside, and each bone has a nice blood supply because that's where you get the osteoblasts and mesenchymal cells into the medullary or tubercular part of the bone that later we talk about will convert into osteoblasts and osteocyte and then bone formation. So we talked about the cells, but let's get into more macro level. Bone structure. This is a cross section of the mandible, and then you can see there are two components to it on the bony part. There's a very white, dense portion, and the middle more spongy-like middle portion. So the outside is very dense, and the middle is very spongy. Well, what are these? Well, the outside part is a cortical bone. All right, so that's one bony structure. And the middle part that's nice and soft is the tubercular bone. And each understanding of each and the ratio of how much of this versus this is a key component, and we'll go on future as we go along in this chapter. So, going back, as you can see, this white strong structure, which is mainly mineralized, versus the more cellular part, which is down the middle with red blood cells. So again, these two parts. And take that same picture. This will be your outside cortical bone, and the inside the tubercular part of your bone. And looking at this picture, you can see the cortical bone is on the outside and the trabecular spongy bone is inside. And I'm going to go over a very particular characteristic of each type of bone. But just to give you an idea, when the implant is placed in, it's initially uh, in bony contact with the soft bone. And then on the outside, like a container that holds everything down, you have this cortical bone. Well, what's a cortical bone? Like I said, the cortical bone is found on the external surface of the bone. Its primary function is to provide strength. It's much more dense, and obviously looking at the quality of it compared to the trabecular bone. Well, how is it relevant to the dentistry? Cortical bone helps stabilize micro movement generated from oblique or non-axial loading of dental implant. What does that mean? So what does that mean? Let's go back in the picture here. So the more cortical bone that we have here, that means the more it protects the lateral movement, meaning right and left movement of this implant, especially if the forces generated are coming not straight up and down. So let's say you have a contact that's coming in from this angle. If you have nice strong cortical bone, it'll prevent the implant movement, that lateral movement, that extra strength that it needs. So that's the advantage of having cortical bone. It really keeps the implant in a place without the lateral shifting. So that's why when we do complicated cases where we're doing an all-on-4 and we're angulating an implant and your loading is not right on the top, it's actually a non-axial oblique, we're trying to find that cortical bone. That's where the bone where I'm looking for when we're doing the all-on-4 protocol, because that's the type of bone that can immediate load and help stabilize those non-axial forces, so the implant is not going right and left, when it's immediately loaded. So that's the advantage of that cortical bone. It prevents lateral movement of the implant and stabilizes it, especially if your forces are coming on a non-axial. The second type of bone we're going to talk about is a spongy bone, the trabecular bone, the part that's right down the middle. That part, it occupies the space that constitute in the cavity and is filled with red blood cells, marrow, and because of those two, because if you have good blood supply and red blood cell, it also helps with increase in healing time, or I'm sorry, decrease in healing time. The bone is very porous, and let's talk about how it's relevant to the dentistry. Like the cortical bone, it prevents micro movement, obviously not to the extent of the cortical bone. It also helps with the stability, but the key thing it does is it acts like a shock absorber. So, anywhere in your body where there's your body needs shock absorber, like your knees and your ankle, that's where you usually find a lot of trabecular bone. So, just for concluding, there's an article that by Golan and Schmidt that talk about the effect of axial, which is up and down, versus oblique, which means coming from right and left, and the micro movement on dental implants. So if you have an implant and the tooth right on top, that will create an axial force on the implant. If you have you're doing, let's say again, you're doing angulated implant, that will create more like an oblique loading. So depending on the type of bone, they concluded that cortical bone helps stabilize micro movement generated from oblique loading. So let's say if you have a tilted, it'll make sure that tilted implant is not distorted because of the loading coming in from a non-axial. And they talk about how the bone density is influenced implant plate displacement. So the more denser, the less the displacement would be, and then obviously more denser means it's more cortical. The loading characteristic, we just discussed about that part. And if the implant is loaded in non-axial bone, which helps stabilizes those non-axial oblique forces and reduces micro movement on the implant, which is basically what it's saying the cortical bone does. So how is it relevant to us? Well, if you're trying, when you have a lot of cortical bone, you're going to have a good primary stability because it's like a concrete. It kind of helps protect the movement of it. And when you're putting that implant in and you're driving that implant in, you can feel it fighting the bone and bone kind of like a cement holding it down. And at the same time, if you don't have cortical bone and you end up with this soft tubercular bone, it's good if you have. So it benefits from quick healing part of it. It also acts like a shock absorber, especially if you have axle loading on the implant. So, when we are looking at the CT scan or we're trying to do the treatment plan, we're trying to find out the ratio between how much the site has cortical versus cancellous bone. And on that basis, we classify bone quality. Okay, so we have nice classification for this bone quality, and the bone quality is classified according to the composition um, of the cortical versus cancellous bone. And the type of classification that I personally use, and it's kind of easy to remember, is MISH classification. MISH classification, and this MISH classification is basically um, uh, divides into and classifies the quality of bone based on cortical versus cancellous bone. And knowing that classification help us in our drilling sequence and maybe even predict the success rate of our treatment plan. So what is so let's talk about MISH classification. There are four type. There are four type. First one is D1, which is composed almost of all cortical bone. The area most found D1 type of bone is the interior of the mandible. This greater amount of cortical bone provides exceptional initial primary stability, and which makes sense because the bone is highly mineralized and dense, and when you're putting the implant in, you can actually feel the torque um, on the implant by the cortical bone. But at the same time, it lacks the blood vessels that are usually found during the tubercular bone. And as you know, from premolar to premolar, as we talked about in our anatomy lecture, the like we have an inferior nerve on the back, in front of the mental foramen, between the two mental foramen and interior of the mandible, is the incisive artery, which is very small. So most of it is basically blood supplies that your anterior mandible receive is from the periosteum. So that's why, the advantages, you do get a strong bone, but the disadvantages, there's a compromised blood supply basically coming from the outside in. So we recommend, that's why we recommend when you're doing interior flaps in the mandible, be conservative on it, because that's where your primary blood supply is being provided. D2, now the ratio is slowly going to start changing towards more tubercular bone. So for the D2 bone, it's composed of a thick crested layer and compact tubercular bone underneath the cortical bone. So now you have still very strong tubercular bone on the outside, but we're also starting to see some nice tubercular bone underneath. This type of bone we usually find sometimes in the interior of the mandible and also on the posterior of the mandible, unlike D1, which is mostly just found on the interior of the mandible. This bone again provides very good stability, but also has intrinsic vascular supply. Like I said, in the posterior of the mandible, you have much wider and much more richly inferior alveolar nerve, so that's giving you some intrinsic vascularization. Even though we lose that as patients get older, but it's still there. So you're getting from two spots, one from the outside in, which is the periosteum, and on the back you also get the intrinsic vascular, which also help provide that trabecular bone nice rich blood supply. D3 is composed of porous cortical bone. So now even your cortical bone is somewhat porous. And your trabecular bone is becoming even more fine. And this can be found in the posterior of the mandible or anterior and posterior of the maxilla. Now, due to the porous nature, the primary stability of the implant is significantly reduced. So the bone contact you're getting is now more to the tubercular bone and less to the cortical. So that affects your primary stability. The increased ratio of cancellous bone does help with osseointegration because the trabecular bone has nice blood supply. So you have good osteoblaster to create bone to have nice bony contact during the healing phase, but it takes time. And during that time, you do lack that primary stability, which the cortical bone generally provides. So you just have, this is a time where you're like, hey, maybe we should not immediate load this implant because it lacks that primary stability. But after it's healed, we can expect good result because there was good trabecular bone and you had good healing due to good vascular supply. D4 is pretty much found in the back of the maxilla. And this rarely you'll find any cortical bone in that area. It's mostly consistent of the fine tubercular bone. So when you're placing an implant in the back of the maxilla, as you should expect, the primary stability is not going to be that good. And when you're torquing the implant in, it's not going to be high because of the um, lack of the cortical bone. So just to kind of review what we just talked about, MISH classification, D1, not all, mostly cortical bone. D2, still a lot of cortical bone, but you're starting to see some nice trabecular in the middle. D3, which you find in the back of the mandible or interior of the maxilla, even back of the maxilla sometime, and obviously D4, which is usually found in posterior of the maxilla. So, we talked about this now. How is relevant, how is all this classification relevant to us? So, as we discussed in our earlier chapter about radiographic analysis, we talked about the Hansfeld unit and how the Hansfeld unit, the higher the number, the denser the bone would be. So now here's a slide that kind of correlates those two information where the higher the number, you're looking at about 1250, you're looking at D1. And somewhere around here would be D2. And as you expect, the lower the Hansfeld number, the compromised the bone quality is going to be. Now, this number should never be an absolute. Each machine has its own reference and number changes, but it gives you a good relativity that if D4 is 350, you're looking at almost 4 times or 3 times the value of D1 would be. So it's all a relative number. So let's take a look at an example of this. So here's a CT scan, and I intentionally picked this one just to kind of show you guys, different reference points. So this patient has a pretty bad abscess around the tooth, so I'll kind of show you what the value of that be in Hansfeld unit versus the infected bone in the interior, and then you'll have the nice cortical bone on D1. We would expect somewhere around here, the mandible and the posterior, the interior of the maxilla, and the back of the maxilla. So let's find ourselves where the infection is. All right, let me get this number out so we can create from the start. Get these numbers out of here. Okay, so here you can see the tooth kind of hanging in the air with the infection. So let's compare those numbers. So let's say if I'm looking at this, I'm trying to true implant it. Let's look at, I'm going to create my Hansfeld unit and look at the number. It's about 45, and I'll even go into the minus numbers, minus 194. And as soon as we go into the cortical bone, you can predictably see the number kind of get bigger and bigger and bigger. It's still not as strong or as dense it would be because there's obviously inflammation going on in this bony area. But just to kind of give you an idea how the drastic the number would change between the abscess area, the cortical bone area, which would be around 200, 300 versus the soft middle bone would be around 54. So even the length of the implant, let's say hypothetically if the infection wasn't here, I will be predicting that, hey, once we go in, I'll expect resistance, then the soft bone would be 19, and then again, if I'm hitting resistance again, I expect the cortical bone on the inferior border. So it kind of gives an idea. Let's remove that, and let's go to the on the other side, on the somewhat of a healthy side, and let's compare our numbers here. So here again, we expect a little bit of from the MISH classification, more of a D1, and you can see that the number they're in 500, 600 area. So this is where the D1 would be. So before I even do the surgery, I know what to expect. So this is how the Hansfeld unit and the CT scan helps predict what's going to happen when we start with the surgery. And if I know what to predict, or if I have information like this, I can accordingly make that treatment plan. And that treatment plan not just means how many implant, but what type of implant. There's certain implants which have very aggressive threads, which are good for cortical bone because they engage into the cortical bone, and that's what you want. You want your thread to engage in the cortical bone, versus not aggressive thread. Once you place them in the cortical bone, instead of engaging, your implant will just want to spin. So here again, like I said, we show you high number in Heinz-Feld unit compared to the abscess or the infected bone. And now let's look at how the maxilla would be, and it would be as predictive as the mandible was. All right. All right, let's look at the maxilla. All right, so this is the back of the maxilla. You're looking at on the right side. There you go. And let's look at our Heinz-Feld unit up here. Look at that. It's in minus right now, in single digits, and on the superior part of it, it's about 193. But look at the palatal bone, where the cortical bone is. It's again 245 and 275, which is again predictable. But look at the difference. You were about 600 in the interior of the mandible, and here, around the first premolar area, you only have about 77 to 90. So again, this is a big advantage comparing to we're looking at a pan. Using the Heinz-Feld unit, we're able to predict misclassification. And once you can predict misclassification, I know when I'm going to put my implant here. Even though you have a nice amount of bone here, the length is pretty nice here. You know, you have almost 15 millimeter of length. You know, you're assuming, hey, you know, it's going to be a piece of cake, but when you put it in, you're trying to put the implant in, you're not going to get that primary stability. And knowing the fact that we're not getting their primary stability, I already know, and telling my patient that, hey, we're not going to immediately load this implant because of the quality of bone that we have here. So this is how we're going to use, or we use the Heinz-Feld unit and misclassification to aid us in treatment planning and really what to expect when we're actually going to do the surgery. All right, so back to our Heinz-Feld unit and bone density. Okay, so in later chapter we will discuss how this bone classification help guide the type of drilling protocol we're going to use. So, you know, just to give you an example, if bone is really hard, you know, you want to make sure you get a good lavage, because cutting through that dense cortical bone will create a lot of heat. And as we go forward, we'll talk about how heat affects in osseointegration and bone healing. All right, so the core of the topic, osseointegration, what's the definition? Is a process whereby clinically asymptomatic rigid fixation of dental implants is achieved and maintained in the bone, and is kept through during functioning of the prosthetic. So basically what you're looking for is nice, strong, rigid fixation, which is almost like ankylose of the implant into the bone, which is asymptomatic and continues to be asymptomatic even after the implant has been prosthetically loaded. So there are three phases of osseointegration. There's an osteophilic phase, osteoconductive, and osteoadaptive. Again, it's a little dry. And these phases, understanding of these phases are very important, and especially during osteoconductive phase where most of your bone is formed, there's also two different paths that bone can be formed. We'll talk about that later also. Again, I know it's a little dry subject, but once you have the clear understanding of this, how osseointegration works, it really help understand the whole concept of implant dentistry. So anyway, so let's go look at our osteophilic phase, which is when initially the implant is placed after the osteotomy. Osteotomy is when we do our drills and make a hole in the bone, just to simplify it. So it's the initially when the implant is placed after the osteotomy, which results in a small amount of bone to implant contact, which makes sense because we removed a lot of bone, and there's some part of it that's contacted with the bone with the implant, and there are other part where you have blood and red blood cells and other cells taking the space. Most is in contact with fibrofatty marrow space and blood, like we talked about. Initial step includes, which it happens everywhere where there is repair, is the inflammation response and starting and maturation of the vascularization, which is angiogenesis. Then you have migration of initial osteoblasts, and then you obviously get the bone formation, starting of the bone formation. So this phase lasts up to 1 month. The second part is the osteoconductive phase. Now, this is obviously very important because most of the bone is laid down during this part. The bone cells spread along the metal surface for the implant surface. The laying down of the osteoid, which is a bone, a thick layer is deposited. The phase continues for the next 3 months as more bone is added to the total surface of the implant. The key thing to remember in this phase also is that 4 months, the maximum amount of surface area is covered by bone, and no further increase in bone to the surface area is observed. So basically, from up to 4 months, whatever bone is being created around the implant, after 4 months, there is no net gain or loss. So whatever you're going to get up to 4 months. So all those osteogenesis that's developing during the conduction phase will happen around up to the 4 months. You do get obviously some bone loss, very minimum after the 4 months as we get older, and we'll talk about later. You lose about 0.01 in a healthy osteogenetic implant every year, but nothing significant. The main bulk of the bone that's created is up to the 4 month. And then after 4 months, it goes into the adaptive phase where there's no gain, no net loss or gain, and the body is pretty much in equilibrium from that side. So, the key part that I'm going to start going to the key part that you should remember and understand. So when we do our osteotomy, you pretty much make a hole, and then you get the blood supply within that cavity. Usually you get about a 1 millimeter of blood supply because you cause the damage to the intraosseous blood supply. And within this blood supply, you have the platelets and the red blood cells. And this vascular disruption on the surface of the osteotomy site during preparation of the implant site leads to death of the pre-implant cortical bone and the trabecular bone. So, when you're doing your osteotomy with the drill, you get the blood, but you're also killing the cells right next to it due to heat or just pure mechanical pressure and forces. The healing at this site is initiated by osteoclastic activity. So what's the first thing that happens is that you have all these dead cells needs to be cleaned out. So that's when the osteoclast comes in. So they're the first guys. And this is also important. I'm going to go a little bit off tangent for a second. Like I said, the healing at this site is initiated by osteoclastic activity. So this is when we talk about in the chapter regarding patient selection and medical history. When we talked about bisphosphonate, this is where bisphosphonate comes in and deactivate this part. So it really just stops the first part of the healing phase, which is the osteoclastic activity. So anyway, so this bone laying down and the sequel of induction of getting bone there are two ways. There is direct osteogenesis, and then there is distance osteogenesis. So we're going to talk about those two in a second. So during the conduction phase, and how do we end up getting bone? So, well, just to kind of have an idea, this is your implant, and in that space that we talked about where you have the blood, you'll have the red blood cells. Obviously, you'll have the platelets. You have initially the osteoclasts that come in and remove all the debris. And then with the blood itself, you also have the mesenchymal osteogenic cell in that area. And the first thing that happens is these platelets all line up. And when they line up, the first thing they do is they create a 3D fibrin network. So you see these lines right here. So imagine like a highway. These are all highway and street. That's the first thing that happens. It creates nice network of these fibrin which attach to the implant. And once they're attached, these platelets and degranulate and basically release cytokines and growth factors, and it creates a gradient difference. So now you see right next to the implant where all the platelets were, there's a strong gradient of all these cytokines versus where the mesenchymal cells were, there is none. So what that does is this change of gradient gives signals to these mesenchymal cells to go towards the gradient, and when they do, they hatch on to one of those fibrins and then really pull themselves, drag themselves with it all the way to the implant surface. So as they're moving onto the fibrin, they're lining it up to be attached right at the surface of the implant. Now, just a little something tidbit here. As they're coming down, these fibrin are attached to these rough surface of the implant. Well, the studies have shown that if there's smooth surface and you have these fibrin attached, what happens is once these cells are migrating on these fibrin, it creates a tension on these fibrin, and it shows that when you have smooth surface, as these cells are coming down, it creates enough tension that it snaps off the smooth surface, which we see every day in our life. When there's something smooth, you put something sticky on it, it comes right easily off. Unlike smooth surface, on rough surface, those fibrins still stay attached. So the cells, the osteogenic cells have the ability to then migrate all the way to the surface of the implant, unlike smooth surface where it will stop because these are fibrins that are snapped off. And once they reach the implant surface, they all line up and they polarize themselves. And from osteogenic cell, that's when they turn into osteoblast. And once they turn into osteoblast, you get the first cement line on the implant, and then these cells slowly start laying down bone. And as they lay down bone from the implant towards the outside, the osteoblast that was laying down the bone basically becomes engulfed into his own bone, and like we discussed earlier in this chapter, that becomes osteocyte. So the new bone matrix is formed. You have blood supply on the outside that keep bringing more mesenchymal and osteogenic cells, which then become osteoblasts, and this you can see how this formation is going, bone formation is going from the implant to the outside, and it kind of goes on and on and on. So that's contact osteogenesis in this case, and that's what we're trying to achieve. Nice strong bone during that second phase to be able to give that good stability to the implant, and so it'll be able to handle all the occlusion forces. Distance osteogenesis is the second part, or one of the possibilities that could happen instead of contact osteogenesis. And in this, the new bone is formed on the surface of the old bone. So compared to contact osteogenesis, in distance osteogenesis, the bone is actually formed from the outside and it's going to go towards the implant. In the previous one, in contact osteogenesis, the bone is actually formed on the surface of the implant and goes towards the outside. So the new bone is formed on the surface of the old bone on the osteotomy site. The interruption of the vascular of the walls of the implant site after preparation of the osteotomy leads to bone death, which pretty much happens on both sides, but it's more meaningful here, and we'll talk about it in a second. The bone healing and formation from distant osteogenesis is illustrated by recruitment of osteoblasts onto the walls of the osteotomy, with a new bone formation occurring again, like we talk about, towards the implant, so outside in. So here's how the distant osteogenesis works. So this is your implant, and unlike the contact, all your mesenchymal cells are actually attached to the peripherally into the osteotomy bone. So you have a nice space in the middle with your vascular supply in between those areas, and these vascular supply actually reform as this bone is being laid down. So here you can see those mesenchymal cells now became osteoblasts, polarized, and they're going to start forming bone. And you can see the bone formation is from the outside towards the implant. But while it's going through that phase, you can see there's always going to be a cell layer and uh, vascular space between the bone that's formed and the implant. So this is the difference. In the contact osteogenesis, you don't have the space, the cell space, this layer right here. Uh, but in distance osteogenesis, you always have this. So just from common sense, you can tell we want to have contact osteogenesis. We want that intimate contact as much as we want. So if this is the implant, you have bone formation right on the top, then the vascular supply for healing and equilibrium. And then in distance osteogenesis, if this is the implant, you'll always have this space in between and the bone. So what are the parameters that affect distance versus contact? Well, obviously the type of bone, the implant surface, as we talk about smooth or rough, and understand that part. This is why if you have a smooth part of the implant, should not be below the crestal bone, because you're not going to get bone formation in that smooth plan because the fibrin won't attach, as we discussed earlier. So looking at the implant you're using, make sure the rough surface are inside the bone at the crestal level and the smooth is on the inside, depending on which implant company you're using. The component of blood clot, obviously the platelets has to be functional. Patients with platelets issue could be compromised. And then knowing all that information, you kind of want to make sure your drill sequence, the type of drilling you're doing, is also effective. And what would that be? Well, heat kills. So as we talked about with you need a good blood supply, good platelets to be able to heal around the implant. You want to create less heat. So, our parameters are the amount of heat should be less than 39 degrees Celsius. And to achieve that, you want to make sure your drill speed, which is what's going to create resistance and heat, should be less than 2000. For us, in our practice, we use and recommend to go even below that. We're way below that. We're below 1000. And when you're putting an implant, same thing. You want it to be 15 and 20. We probably even go less here. And, understanding that part, that why you want to be below 2000, even 1000, you also have to keep in mind what kind of bone you're drilling to. Because if it's cortical bone, drilling 1000 could create a lot of heat versus soft bone like a trabecular bone. So it all kind of comes together where understanding the characteristic of your patient's cortical bone and the cancellous bone, understanding the characteristic of that bone. Once you understand that, you can characterize bone, and we understand to use Misch classification to understand this cortical versus cancellous bone ratio. And once you know that ratio, you'll be able to predict in future when you go in how strong the implant would be torquing in, and should you be able to do immediate loading or not. We then talked about osteointegration. We talked about 3 phases: the osteolytic, osteoconduction, and osteoadaptation. And we talked about within the conduction and creating of the bone, the 2 type, distance versus contact. We talked about how distance it's from the outside in, and the contact is bone formation from the implant to the outside, and is the intimate contact that we'd like to have. And then knowing these factors, we understand how that would affect our surgical protocol. All this information, how directly it affects our surgical protocol, where we can get predictable osteointegration. So knowing that more cortical bone will give us more primary stability, more cancellous bone will give us more quicker and faster healing. The type of bone classification will give us predictability if we can do immediate placement, or how many more implants we might need. 3 phases, so we know after 4 months, that's all the bone we're going to get. After that, net it's going to be 0. And then we talked about our drilling sequence, how would that be affected. Keeping heat down, a lot of lavage to keep it cool so we can actually get contact osteogenesis. And all that is, so I hope you get a good understanding of bone physiology and osteointegration. When we actually will go into the surgical part and the surgical protocol, you, you, you should be able to use these basic concepts and now starting to think about it and analyze it and predict what's going to happen, and using obviously CT scan and Hounsfield unit to be able to get what MISH classification would be. So this is my one of my favorite slides, and in conclusion, it gives us a good practical aspect of what in theory we have learned so far about bone physiology and osseointegration. And beside the using the tools of radiograph to predict the D1, D2 MISH classification, and then the protocol, this is another very good slide to use our theoretical knowledge into practical use. So when have you noticed when I talked about primary stability, just to recap, it's the torque when you're placing the implant into the bone, how stable that implant is within the bone, and this is a line right here. It's called the primary stability line in this graph, and is measured against the stability of the implant. So when we initially place an implant, believe it or not, assume that's 100%. That's the most primary stability you're going to get at that point. As time goes by, you actually lose that primary stability. So as weeks go by, at week 4 approximately, it would be your weakest primary stability. Why is that? Well, we talked about bone death after the osteotomy, and it takes time for the bone healing, the second stability, which is the new bone being formed, it takes time for that to happen. So as the primary stability goes down and is weakest at week 4, you have the bone healing, which is obviously 0 to start with, and slowly creeps up. And at week 4, it's not strong enough to keep the implant at its highest stability. So we have to be very cautious around the week 4 margin, because you have lost enough primary stability but haven't gained the new bone or the second stability to make up for the deficit. So you have that a decrease in stability at the weakest part, which is week 4. And as time goes by, the bone healings takes place, and then it overcomes and stabilizes the implant enough so you're back to your 100% stability. So this is why when we do our immediate loading, we always talked about that do not have the prosthesis in and out during this crucial week 4 to week 10 time, when the secondary stability, which is the new bone, hasn't completely formed yet. And we talked about it, and it takes up to almost 4 months, 3 to 4 months, for that complete bone stability to form. But you might not need to wait up to 4 months. Our guideline is usually after 12 weeks, which is roughly 3 months. You should be able, you can go back and take the prosthesis out and be comfortable, because the secondary stability is almost finished and your implant stability is all at 100%. So again, this concludes our lecture on bone physiology and osteointegration. Thank you.